Well, anyways, I'm very delighted to be here, and I wanted to thank Felicia Nall and Dr. Erin Kovitz for the invitation. I was asked to speak a little bit about what CDC does in cancer, both domestically and globally, and through that, I hope that you will understand why we handle how we synergize basically breast and cervical cancer. And I wanted to acknowledge one of my CDC colleagues, Dr. Nelson Arabadella. Do you want to raise your hand, Nelson? Just forward it. I'm so sorry. It's not moving. Okay, so this is one slide that I'll go through quite fast, and you will all have copies of it to see the organizational chart. And the point there is just to say that CDC is a huge place. A chronic disease, we don't call it non-communicable disease all the time, is in several places. Just recently, we've started the Center for Global Health has a chronic disease unit that liaisons with a lot of the centers that actually do chronic disease work, like heart disease, stroke, diabetes, cancer, and many other groups. And so it's an area that's burgeoning, and the fact that there is a unit in the Center for Global Health shows that this is a high priority. So domestically, what does CDC do in cancer? We work on cancer registries. So now in the United States, we have a cancer registry in every state, so 100% population coverage. We work on national comprehensive cancer control plans. As you know, the U.S. doesn't have one cancer control plan. It has 50 plans. And so coordination of those 50 plans requires a lot of resources, as well as, and it does vary by state. We have a breast and cervical cancer early detection program, which is how the CDC actually got started, and I'll talk about that. And of course, colorectal cancer program that was recently started. So, in the 1990s, we started the National Breast and Cervical Cancer Screening Program, and you can see the trajectory of what CDC has been doing. 2005, we added colorectal cancer screening, and the whole program is evolving with the Affordable Care Act, which allows more of these clinical preventive services to be accessed. What we're finding through the Affordable Care Act is that there's many groups that are still being missed for cervical and breast and colorectal cancer screening, so we believe that the program still has an important place, especially when we think about immigrant populations. When we think about who is not getting screened in the United States, it's people from Latin America, the Caribbean islands, African populations from countries, so we're actually monitoring that as well. So the program was established by law to reach poor and underserved women for cervical cancer screening and breast cancer screening. And these are just some of the ways that what the law subscribed for the CDC to implement. Important issues to consider would be that there was a matching for $1 that the CDC put in. For $3 that CDC put in, the state would have to put in the equal amount, at least $1. We had something in place to make sure how new technologies were used. 40% of the funds that the states received went beyond provision of clinical services, which I think is really important. So that's what made the program a little bit organized. We often say it's the only organized screening program in the United States. This is just the public health model for the screening. This just shows that almost every grantee in the United States, including American Indian natives, receive money from the CDC to implement cervical cancer screening. And this has been really important for the Native American population to decrease the mortality for cervical cancer. We've screened, this is a little bit date old, but we've screened many women for both breast and cervical cancer and diagnosed many precancers and cancers. One of the nice things that I like as an epidemiologist is that we've actually established these minimum surveillance data elements that every state is required to report on, and they have indicators associated with them. So this was begun from the very beginning of the initiation of the program, not an afterthought. So, and it's tied to funding with the individual states. So here's an example of the quality indicators for program performance and how each of the states have met those qualified indicators. And to highlight that follow-up is just as important as coverage in this program. So as a result, there's been many papers that have been published that show that women that are screened in the program actually receive diagnostic follow-up and initiated treatment, which you will see in many countries that have started pilot programs. That's where the problem is, the loss to follow-up. And so I think that this is important because there have been indicators on the follow-up and treatment, and almost a patient navigation kind of style has been initiated in each of the health departments to make sure that women are being followed up. Our economists, of course, have conducted studies to show that both the women that are screened for breast and cervical cancer screening, they're in terms of life years saved, shows that there have been improvements in their life years saved. And what we have highlighted is that how that compares to other interventions that show life years saved. So CDC also has a global footprint, actually, and there's 1,700 staff in 60+ countries. Nelson Arbadillo is just one of those staff that's assigned to the Dominican Republic and Haiti. This is a map that shows where CDC staff are housed in pink, that we actually have CDC staff overseas, and then the blue part just shows that there are areas where there are activities occurring but not necessarily staff. For the Global Cancer Group, we are a small group, but we work in developing tools, providing technical assistance, and training. So I'm going to talk a little bit about that. The areas that we work on in cervical and breast cancer screening, improving cancer registration and use of the registry data, capacity building, and translating the lessons from domestic work to global work. And this is why I think working with Latin America and the Caribbean is very important to us, both from the domestic perspective as well as the global perspective, in terms of the populations that we think are underserved here in the United States usually come from the countries that we're closest in proximity to. One of the toolkits that we've been part of and happy to be part of is a Bill and Melinda Gates Foundation grant activity that focuses on several different aspects, and I'm going to talk about them in more detail. One is it went into 6 countries, including one country in Latin America, Guatemala, to look at a data systems assessment in terms of what exists in different countries to monitor and evaluate. We've also been directly involved with this population-based survey for cervical cancer screening and treatment. Many of you know that as a country, you're asked to look at how many women are being screened in your country for both cervical and breast, but where do these data come from? In the United States, the data come from population-based surveys like the BRFSS. In many of the other countries, they come from surveys like the STEP survey, the Demographic Health Survey, or the HIA survey, which is an HIV-associated survey. But many of the questions ask different questions, and so there's a loss of comparability. And so we've developed some standardized questions that countries can use, and we're translating them as well, and that should be available. This entire toolkit should be available by the end of this year for dissemination. For cervical cancer, we have patient and program monitoring and facility-based surveys where people can look and see, if a woman is being screened, how do you actually put the data together? And then we have a costing tool as well. So all of these tools will be available hopefully by the end of December. But what I also wanted to highlight was that there was a solid approach to this. There's no reason why breast couldn't have been added. There's no reason why colorectal cancer couldn't have been added. But I think it's highly dependent on the donor and the approach in terms of what the funds can be used for. But I can easily see this being translated for breast cancer screening indicators. The future toolkit use, as I mentioned, we're going to be working with PAHO in Latin America to disseminate this tool. The surveys are already asking these questions, and there will be, as I mentioned, why would we need to have a different process or different funding stream when we could easily have incorporated it from the very beginning? Another tool that we've developed is a costing tool for cancer registries. many countries want a cancer registry or some kind of registry, but they don't know how much it costs. So what we've done is taken a tool that we've used in the United States, adapted it to the global setting, piloted in these 5 countries, and we will have a monograph that's coming out in cancer epidemiology to show the results of those, and it gives a rough estimate of how much it costs to run, start, or maintain a cancer registry. What we're planning on doing is creating a web-based tool and hopefully housing it with the International Agency for Research on Cancer so countries can use that at their will. And what I wanted to mention was that the whole discipline of economic programs and costing programs is a very important aspect of the work that we do domestically. And so we're happy to take those tools that we've developed, like we did for cancer registry, and adapt them for cervical cancer screening, breast and colorectal cancer screening, because it's more about programs, so programs know where their money is being spent. So this is just an example of the countries that we worked in and how they know that most of the funding that's coming for cancer registry comes from the host institution, like an academic institution. This slide shows that most of the costs for running a cancer registry come from labor. So when we actually have electronic medical records, we might actually see a significant savings in this area. One tool and training aspect that I wanted to talk about was the field epidemiology training program. Dr. Frieden, our director, considers this the single most important thing CDC does in global health. So I wanted to just spend a few minutes talking about that. So FETP is an on-the-job training and service for field epidemiologists, and it's focused on training through service, so not through lectures. And the class time is kept to a minimum, and there's 3 types of FETP that have been developed. The one that I'm most familiar with is the advanced FETP, but you can see that CDC supports approximately 65 of these FETP programs, mostly in sub-Saharan Africa, less so in Central America and Latin America, but that does change based on the funding stream. And the front line is basically those that will just need 3 months of training. The 9-month training is called the intermediate FETP, and then the advanced FETP is those that is for epidemiologists. And then basically these epidemiologists actually do stay in the Ministry of Health and do work in that area that they were trained in. This is just an example of the networks that the FETP works in. They're usually divided by regions. So if you do all get a chance to go to the tefinet.org website, you can actually see modules that have been developed. So we have developed a cancer curriculum for the FET program that will be available by the end of this year. And we have basically 5 modules. And the modules really are for people who are working in the Ministry of Health, so programmatic issues to be concerned about, ranging from cancer registries, cancer screening. And we've piloted it in India, Morocco, and Atlanta, and Nigeria. We just got it translated in Spanish, so we may be doing a course in one of the Spanish-speaking countries. And what we do after we do the training is that we give money to the people who attend it based on a competitive application. And I've been really surprised that almost everyone that's applied to work on it, 2 from Mexico, 1 from Thailand, many from India, they've all been focused on evaluating the breast and cervical cancer screening data. So that is something that that's of high priority. And they're young epidemiologists that usually are going to stay in the Ministry of Health. And so that's nice because one of them was from India evaluating the Tamil Nadu program. In the interest of time, I just wanted to speak about the U.S. Virgin Islands and the U.S. Pacific Islands. Those are also part of us, the United States. And so, but in many ways, they're more of a low-income setting, so we try to improve coverage. And one thing that we're working on is to improve cervical cancer screening through self-sampling and HPV testing. And we also work closely with Latin America, and we've been involved with several policy dialogues. And Thailand as well. And what I wanted to just briefly comment on is that I think that there's a lot to be said about synergizing with breast and cervical cancer. One of the things I've noticed in my limited global experience has been that the breast cancer has the strongest advocates. We have seen that, and I think that it's a great opportunity to sort of link the cervical cancer advocates to the breast cancer. I often go to cervical cancer survivor meetings, and they're still stigmatized about their cervical cancer. They can't talk about it, even in the United States. No one is willing to sort of come up and talk about their cervical cancer. There's several platforms that can be leveraged. I think the challenges sometimes for breast and cervical cancer are the target ages. We've noticed, as you've mentioned, PEPFAR has sort of been responsible for why there's a lot of cervical cancer screening in many of the sub-Saharan African countries, and that's because it's directly linked with HIV. While there's attempts to add breast cancer to it, I think it's met with a little bit more challenge. And then, as I mentioned, the stigma. Cervical cancer also has some advantages compared to breast cancer because of the primary prevention strategies, the whole idea of screening and treating in a single approach as well. So thank you so much. All done in 10 minutes.